Today, we're going to be talking about the specialty of palliative care. And it's definitely a specialty that I don't think most of us know what it really is. In fact, I thought I knew until I went to AAPA this past year and saw this speaker give a presentation about palliative care. And I remember just sitting there going, yeah, I did not realize that this is what they do. And I started thinking about all of the patients that I could have referred to palliative care that would have benefited from it, but I didn't know really what it was. So, if that's you, if you're interested in the specialty as a potential specialty you might want to work in, or if you just want to learn about what kind of cases and patients to refer to palliative care, then stay tuned.
Thanks for having me. My name is Tracey Piparo. I am a PA in central New Jersey, practicing for the past 22 years.
The first thing I think that we have to discuss when we talk about palliative care medicine is palliative care the same thing as hospice?
Yeah, great question. It's a perfect place to start. We're not the same thing. It's really hard because in all of the professional circles, it's always hospice and palliative medicine, right? So people get really confused. The way I like to explain it to folks is palliative is a big umbrella. So anyone with a serious illness that could be life limiting, perhaps, but a serious illness, which would be, characterized as anything that is affecting someone's quality of life, that is needing significant treatments and creates burdensome symptoms, but also creates some caregiver burden. Lots of people forget that serious illness can have an impact on the caregivers for folks. So anything that would fit into that criteria are patients that would deserve the support of palliative medicine. It doesn't mean that they cannot be pursuing what could potentially be curative treatments. When the time comes, if it does, that there are no more curative treatments, disease directed treatments, or perhaps the patient decides that these treatments are now not in line with their goals or do not support their quality of life, and they've chosen to spend more time focused on quality of life, then that's when we talk about having the support of our pals from hospice. Palliative is really a big continuum. I say it's a big circle, and hospice is a really small circle within that.
And I venture to say that most people like me probably don't really even understand palliative care and how they can be using it for their patients. Do you find that to be true?
Yeah, I think definitely, it's a relatively young specialty when you really get down to it. And when you talk about PAs being involved in it, we're like the babies of the group, right?
Yeah.
So, but we're small but mighty. The latest, NCCPA numbers were less than 200 of us across the United States as of 2023. But the first test, I believe, will be given in 2024. There is a CAQ through the NCCPA for hospice and palliative medicine. So it just gives us a little bit more, shall we say, street cred in
Yeah.
saying that, this is our specialty and we want to be considered, awesome at this. Really, anybody in any specialty, you have to keep palliative in the back of your head because no matter what you're doing, you have the potential to see someone with an illness that, is affecting their quality of life. And I always tell folks these are the people that after you see them, you walk out of your office and you're like, oh man, this must be really hard. Well, if you're saying that to yourself, please think about using us.
Wow, that is simple and powerful and something I never even thought about. So I love that you just said that. One thing I want to back up a little bit when we're talking about PAs in palliative care. What about nurse practitioners? Are there a lot of nurse practitioners?
It's super nurse practitioner heavy. And for several reasons, I think early in the days of palliative really becoming a specialty itself, before there was a fellowship for physicians, there was a lot of involvement from nurses. And that naturally evolved into the nurses who did this, especially through working with hospice, were the ones who became nurse practitioners and then moved into doing palliative care nurse practitioner. My team in particular, I work with 3 nurse practitioners who are fantastic. And again, I think the positive of palliative and having all the different teams that work, or I should say, folks that comprise a team. Palliative in and of itself is interdisciplinary. So, nurses, social workers, nurse practitioners, PAs, physicians, chaplains, we all work together. We all have a common goal. So, to me, whatever you choose to do, great. But if you find your way to palliative, I'm happy to work with you.
So, kind of going back to the patient population, so you said it, anyone going through serious disease or having a tough time. And I think that most people would probably think that you are 99% of your time working with the elderly, especially people like over 80. I'm sure you have a good amount of those patients, but do you ever work with younger patients, or is that another misconception people have?
It is. It's a common misconception. It's just like everybody thinks we only work with cancer patients. I would say, again, I have a little bit of a skewed view because I'm doing inpatient palliative right now in a major, pretty much metropolitan area. So we are a catchment area for tons of different things, and we have a bunch of specialty associations there. So we see a lot of high volume and really high acuity patients, but it runs the gamut. I have anyone from 26, I'm thinking about my census right now, 26 to 97 on our census. And again, it's because you have to think, what is a serious illness? Like, you have a young person with non-ischemic cardiomyopathy who is going through advanced heart failure therapies and is maybe waiting to get an LVAD or even a heart transplant. Lots of people don't know that part of getting workup for a heart transplant, even if you're doing great, you're outpatient, you're feeling awesome, is having a palliative care consult. JACO actually has that as part of the transplant process because they recognize that having that support of another team who is like, hey, really, how are you doing, makes a huge difference.
I know you can't list like every patient you've had, and there can be the whole gamut, but what are the conditions that people have that you are seeing the most?
Obviously, cancer, that's the one that everybody thinks of, right? But my thing is, I think cancer highlights perfectly the relationship when we try and separate palliative from hospice. There are cancer patients who are survivors. There are cancer patients who have no evidence of disease after 5 years, after 10 years. It doesn't mean that when they are in the throes of getting all their treatment, they don't deserve the support of palliative. So we want to meet those folks. So, all right, cancer, heart failure, any end stage lung disease, COPD, pulmonary fibrosis, transplant patients, end stage renal disease. People do great on dialysis until they don't. Wouldn't it be better if they have someone to kind of support them along the way and to start those more difficult conversations when things start to go, the very predictable way we can sometimes see them going?
Yeah.
Different congenital disorders. I know a lot of my peds colleagues would be able to talk a lot about that. Pediatric palliative is the same but different for adults. Oh, we get a lot patients with dementia,
Oh,
patients who have traumatic injuries, who have now had a huge change to their quality of life. I work in a level one trauma center, so we get a lot of folks that are suddenly paraplegic, suddenly quadriplegic. If we don't recognize that that's affecting their quality of life, then we're doing a disservice.
so in my mind, tell me if I've kind of got this right. A hospice is helping people like manage their pain, navigate through what the end of life looks like. Whereas palliative care, you are helping people through serious illnesses, whether they may be heading towards hospice and the end of their life or not, whether we expect them to improve and continue on their life for many years to come. So when you're there helping them, you're helping to manage pain. I assume, are you kind of like directing the care and overseeing, like being the person that's
Yeah.
putting everything together?
You're doing a great job.
Oh, thank you.
Um, Yeah, the other distinction I'll make when patients choose hospice as a care plan is that the hope is and the goal is to stay out of the hospital. Hospice is for folks who are like, I'm done. I don't want to come back to the hospital. I would like to spend whatever time I have left, and we don't know how long that is, outside of the hospital. So that becomes the goal. Palliative medicine, no, that patient is still pursuing active treatments. What the palliative team does is really say, hey, how do we make sure that these treatments that you're being offered from whoever's taking care of you, your illness, the care team, are in line with what is important to you, which ultimately makes up your
Mhm.
goals of care, right? I tell everyone, I came from an ER and then a hospitalist background, super medicine heavy, right? We're going to diagnose people, we're going to have a differential diagnosis, we'll figure out what's wrong, we're going to treat it. Palliative's so much different because it really is more of that support aspect of it and working with the care teams who are doing that minutia of the medical stuff. So we may not be directing things, but what I tell patients a lot is I'm like your coordinator, right? I'm the holder of information. And if I don't have the information, I'm going to find it for you because my job is to make sure that my patient and their loved ones have the best information available to them so that they can make the best decision. And it's not right or wrong. It may not be something that I agree with. It may not be something that their surgeon or their oncologist or their cardiologist agrees with, but it doesn't matter, right? Because it's not about me, it's them. And yes, and manage symptoms, pain, anxiety, nausea, vomiting, constipation. And I'm not saying that my colleagues in other specialties cannot do that, but let's face it, like, I don't think I want my cardiologist who's trying to work me up for a heart transplant trying to manage all of my anxiety that I'm having about this transplant because I need him to really concentrate on the other things.
And I imagine that you are having those tough conversations with people, really taking the time to tease out how much treatment they want, what is enough for them, what will they accept and tolerate, and help them figure out what that point is that they don't want to cross. Is that what you do also?
Yeah, I mean, I think what you're alluding to is people's goals. Sometimes people have a very specific goal. My daughter is getting married in 6 months and I want to be there. Or my grandchild is being born in 2 months and I just want to see them born. Okay, great. Then, the ability to communicate that to a team, like an oncology team or a surgical team, and say, hey, this is the goal. How are we going to now get this patient there? So, that ability to really empower the patients to share that information with you and then break down how they get there and what they need to have in place.
And that's something that all of us can be doing in our practice because there's not enough palliative care people to just send everyone to just to have that conversation.
100%. That's the role for what we call primary palliative care, right? Family medicine, internal medicine, surgery, orthopedics, cardiology, nephrology. Everyone should be sitting having these conversations with folks, especially when you're talking about things that could potentially affect their quality of life. You know,
Yeah.
you need dialysis. Hey, let's talk about if things go great, that's awesome. What if something happens? What are you willing to accept?
I hear you saying that there are options in palliative care to work just outpatient or just inpatient or even maybe a mixture of both. Is that correct?
Yeah, we're everywhere. We have a bunch of hospitals in our system. We're one of the biggest teams. There's one hospital in our system that only has two nurses, and they
Oh,
try and do the best that they can. There are a couple of companies that are coming into light that are trying to do palliative
yeah.
visits to, working with nursing homes and getting contracts and going to nursing homes and doing palliative visits for folks. I think the industry and insurance and things are realizing that having the support of palliative is ultimately cost saving on the back end. It's very difficult to quote prove my worth on the front end. But I can say maybe a month from now, hey, that patient who was in the hospital for 27 days, I saved you on length of stay because I got them out because they finally, they accepted hospice. Or I saved you an ICU admission because I got to a code discussion with a patient and they wanted to protect themselves from that. So there's plenty of
Mhm.
opportunity. And outpatient, I think, is really thriving. And I think that's where we're going to see a huge lift of needing more providers. Also, what I see happening and what in my perfect world I envision is patients and families are going to feel so much more empowered to ask for something like palliative because they're going to be like, whoa, these are the people who are going to listen to me.
Yeah, but do you actually have time to listen to your patients? Like, how many patients are you dealing with on a daily basis?
Yeah. The one thing I like to say to put it in perspective for folks who, even if you're medicine or surgery heavy, right? Everybody has certain procedures. Again, coming from the ER, you drop a tube in somebody, you do an LP, it's a great night, right? Like you got to do a couple of procedures, but that takes time, right? That you're going to dedicate your time to suturing somebody's face. For me in palliative, my procedure has become the conversation. A typical day for us, we've kind of tried to set some boundaries for ourselves is we attempt as a team not to expect any of us to take more than 2 new consults a day,
Okay.
and we try not to carry more than 10 patients at a time each because it's hard. A new consult average is gonna take me 45 minutes to 90 minutes just to finish, and that's not typing my note. And our notes are so narrative that it can take me 35 minutes to just get through a note sometimes.
There are people in medicine who I think just love to write narrative notes like that. So it seems like this would be a great fit for a person like that.
Yeah, I think if you're the type of person that really wants to get to the nitty-gritty sometimes, my biggest thing I always ask people, and some of my colleagues laugh at me because I'll come back and be like, "Oh, I just met the best retired truck driver." And they're like, "What are you talking about?" It's always one of my first questions. Hey, when you're not in the hospital, like, what do you do? My little nonogenarian, little man loves when I say, bet you're retired, right? You're not still working, are you? And they love it because they're laughing and they're like, are you kidding me? And then they love telling me what they did because I want to
Right.
know where they're coming from, right? If you're the type of person that gets you going, palliative is probably for you or could be for you, but that's with the caveat of the conversations have the ability and often do turn very quickly. And listen, it's not for everybody. If you cannot sit there and have these harder conversations, meaning you are going to normalize death for people, you are going to share some serious stuff with patients and families.
I think some people might look at this specialty and say, "Ugh, that's a lot of doom and gloom, a lot of death, and it's got to be depressing to work in it." Is that how you see the specialty?
No, not at all. Our body is going to shut down one way or another. If I can play a small part in making that be the most compassionate and dignified end of life and support you and your family through that, if I get a thank you, that just puts the icing on the cake. But
Mm.
if I just know that I did the best I could do for you, that's what keeps me going. Because if I
Yeah.
didn't think about it like that, yeah, I'd come home and be miserable every night.
So people are watching this and they think, okay, I could have those hard conversations, but I don't know that I really know how to do that. And I've worked in maybe some family practice, but I don't know, do I have the medicine skills that I'm going to need? What are your thoughts on that? Like, how experienced do you have to be?
Yeah, that's a great question. My big recommendation to anybody is get your feet wet, right? As wet as you can. See sick, see people dying, see people getting better. But you gotta know sick from not sick. I should correct that. Not even sick from not sick. You have to know this patient has some time for me to spend and talk to them and work out things that are important to them. Or holy moly, I may need to ramp up my ideas here. And again, I'm coming from a skewed view from the inpatient side. But even in outpatient, palliative medicine, you may start seeing someone early on in their journey, whether they have cancer, heart failure, maybe they're perfectly managed with goal directed medical therapy. But when push comes to shove, you need to recognize when they walk in your room one day that they look different, and you're not going to know that unless you see hundreds of patients with CHF, unless you see hundreds of patients with cancer. So to me, you have to know your medicine because you also got to know what's important and what's not. And you can appreciate, and I don't even think I appreciated this until I was doing palliative full time, that like there is the ability to manage a lot of symptoms with medications and other alternative things rather than just jumping to what we would traditionally do. I don't need to put a tube down someone's throat. I don't need to, put them on on continuous BiPAP. I don't need to do a thoracentesis on somebody if I can control their shortness of breath with a little bit of opiate. But you can't appreciate that unless you've done all the other things first. The conversation thing, I think, yes, you got to be a person who doesn't mind talking to people, but you can learn a lot of it on the job.
Yeah.
There's plenty of training things out there, Vital Talks, Serious Illness Conversation Guide, by Ariadne Labs is awesome. So there's ways that you can perfect it. I've been doing this full time now for 2.5 years, and every day I pick up a little nuance that I'm like, oh man, I got to put that in my arsenal because I got to remember that.
I'll put links down below in the description box if people want to check those out. But if somebody wants to transition to palliative care,
Yeah.
and or if somebody is in school and thinks that this is going to be something for them in the future, can you give them some ideas, advice on what to do?
I think critical care, get yourself into an ICU, any ICU, neuro, cardiovascular, MICU, SICU, spend some time there. Emergency medicine is great, but not completely necessary. Any type of internal medicine, family medicine, because you are going to see everything. The internal medicine side of it, I think, is where you get to see the social aspects that we deal with and more of the psychological aspect of what we deal with, because you're seeing the patients who are like, I didn't pick up my prescription or I didn't have a ride to the office. Because those patients who didn't have a ride to the office become the people who are going to have trouble getting to their treatments or going to be the people who maybe they're ready for hospice and you're talking about that, but they don't have anyone to take care of them at home. So now you got to
Right.
figure something out. If you can spend some time even just talking or learning more about oncology stuff. My cancer knowledge was very little. I've learned so much. And I think if you're able to come in with a little bit of knowledge about it, it's great. My other suggestion would be geriatrics. People always forget
Oh,
about the specialty of geriatrics. Again, although we said earlier in the interview that, not all my patients are over the age of 65, it's where you're going to see the majority of disease process.
yeah. And that disease process, as if you learn about it, that can apply to a 30-year-old going through that disease
Correct.
process too. But you've learned it because you see it more often in geriatrics. That
Correct.
makes sense. Yeah. So when we're talking about salary, could you give us some kind of range?
I did a little background research on this, so I would be prepared. I am compensated, in my opinion, very well where I work. But again, I've been part of the med staff there for 21 years. So a lot of it had to do with my prior experience. I think if you're working for a big system, it's going to be a lot different than working for one of these private agencies that does, home based palliative medicine or a private practice that wants you to be their palliative person and maybe they're doing heart failure or oncology. So I think although it stinks because it's going to be a big range depending on experience and where you are. I think anywhere from 115 to like 170,000. I know it's a really wide range and people are going to
No,
be
that's
it's
yeah.
unhelpful. If you're walking in and you have 2 years experience, like no one's going to pay you $150,000 to do palliative.
That gives us an idea, and then an idea that with years of experience and time, you can make sound like fairly decent in this
Yeah,
specialty.
I'm super involved with PA advocacy and stuff too. And I think one of the biggest things that we need to learn to do better for ourselves is advocate, number one, in so many different ways. But advocate for yourself, which will include your profession, right? Especially in palliative, because again, there aren't even that many palliative boarded physicians.
Right.
There's a huge opportunity for us to really make a name for ourselves and really be like, hey, we got a seat at this table and we can do this.
Palliative care is your thing. It's what you do. I can tell that you have a real heart for it. And I understand that you have like some social media kind of dedicated to palliative care. Is that correct? And can you tell us a little bit about that?
Yeah, social media wise, couple of things. One, we do have a page on Facebook for PAs who are interested and or practicing palliative. It's called PAs Are Perfect for Palliative. We get pretty good discussions in there, and sometimes it's just good to go there even when you have a bad day and have someone understand. On Instagram, I'm your palliative PA. Feedback has been pretty good because it's like you said earlier in the interview, people don't realize the patients that we can help. It's great to share with family members. It's not just medicine focused. I really
Okay.
just try and share general information about palliative and the benefits of it.
Well, great. Well, I definitely will have links to all of those down below in the description box. And I really hope that this specialty becomes more normalized and that people think about it as something to go into, but also to remember that your patients can benefit from palliative care and to refer when you can.
Yeah, thank you. This has been
Uh,
awesome.
If palliative care isn't for you and you're still kind of looking for that specialty that resonates with you, or if you're just curious what your colleagues are up to, then you can watch this playlist here where I interview PAs and NPs working in all the various medical specialties. As always, take care, stay sane, and I'll see you next time on the medicine couch. Bye.